start.
Thank you for this interview, Dr. Ben. We would like to ask you prepared questions about spina bifida and hydrocephalus. We knew that those conditions are serious birth defects. Can you tell us what today's surgery can do to minimize these defects and resolve these issues?
Okay, well that's a big question. The standard treatment, which has been for some time, is to deliver the baby by cesarean section when the diagnosis is made during pregnancy. The reason for that is that there's some evidence that delivering the baby the normal way may produce some increased damage, neurological damage. So most people will recommend delivering the baby by cesarean section. And then soon after birth, the back needs to be closed to prevent infection. That doesn't do anything to make the nerves work. You're not putting anything together to improve function, but you're basically providing the coverage for the nerves and the spinal fluid sac to prevent meningitis. The majority of the babies will develop hydrocephalus because they all have, to some degree, an abnormality of the brain that we call the Chiari malformation. That's a confusing term because there are different types of Chiari malformation. This one happens to be called a type 2, and it involves an abnormality with the back of the brain being descended through the base of the skull, along with a number of other brain abnormalities that can vary in their degree of how bad they are. But what they have in common is that the abnormality back here interferes with the normal circulation of the fluid that's made in the brain, the cerebrospinal fluid that's made in the chambers inside the brain that we call the ventricles. And that fluid is constantly produced and makes its way out of the brain to be absorbed outside the brain. In these children, that circulation is not normal, and they develop what is called hydrocephalus, which is an entrapment of that fluid, which causes the ventricles to enlarge under pressure. When this condition is progressive, then it needs to be treated to prevent damage to the brain that's trying to develop and grow. There are two ways to treat the hydrocephalus. The standard treatment for this for the last half century has been to place a tube into the ventricle of the brain, to implant a tube that stays there permanently. This is connected to another tube that's underneath the skin and goes down into the abdominal cavity, and that's called a shunt. It allows the fluid to escape through the tube down into the belly. That is fine and it works, but the problem with shunts is that they almost always fail at least once, on average 2 or 3 times at least over the course of the child's life, the child with spina bifida. And that can be dangerous. If a shunt malfunction occurs, it's often an emergency. So there's an alternative treatment which we've been applying for the last decade or so, which involves 2 components to the procedure. One is to do something called an endoscopic third ventriculostomy, which involves placing a small, flexible endoscope, a scope into the ventricles, the cavities of the brain, which is attached to a camera, and you can see inside the brain on the TV screen. And through that scope, you make a small opening in the base of the brain, a place called the floor of the third ventricle. And that's why it's called a third ventriculostomy. Ostomy just means making an opening or making a hole. And by penetrating the floor of the third ventricle at the base of the brain, it allows a route for the fluid to escape out of the ventricles of the brain into the normal fluid space where it wants to be absorbed. That works for some of the children, but in little babies, this procedure that we call an ETV for short, endoscopic third ventriculostomy, In spina bifida babies, it only works about 1 out of 3 times if you just do that. So what we found a number of years ago was that in babies, if you also, at the same time, reduce the amount of tissue in the ventricles that is producing the fluid, a tissue that we call choroid plexus, reduce that by cauterization or burning back, shrinking the tissue with a little electrical current, it greatly increases the likelihood that the ETV will work. We call that part of the procedure a choroid plexus cauterization, or CPC for short. And when we combine these two procedures together at the same time, we're able to avoid placing a shunt in 3/4 of those patients, about 75% of the patients. This is a big difference from what it was like years ago when I was in training, when we were taught that 85 or 90% of these children require a shunt. In truth, if you are a little patient and wait, about maybe 1/3 or so of the babies will resolve the hydrocephalus and require no treatment. And in those that do require treatment, if you treat it with the ETV CPC procedure, 75% of those will not need a shunt in the long term. And so really only about 15 or 20% of these babies should require a shunt, which is quite different than the way it used to be. In terms of other things that are new in treating these children, in the last few years, people have been exploring the repair of the defect in the back while the baby is in the womb, before the baby is born. This fetal myelomeningocele repair does seem to have some benefits. It may, on average, allow for a little bit better mobility, because the level of paralysis on average has been shown to be a little bit lower. And it also probably reduces the severity of this brain malformation that I described, the type 2 Chiari malformation, and also reduces the need for the treatment of hydrocephalus. The downside, the negative side to that approach is that it does have some risks to the mother and the fetus. So there is a risk of spontaneous abortion, losing the baby. There is a risk of premature birth that's significantly elevated, and if the baby is born very prematurely, that can add additional problems like cerebral palsy that the baby might not have had to have. And then finally, there are maternal risks. The mother is undergoing an operation as well as the baby, and the opening that's made in the uterus that's then closed up puts the pregnancy at some risk after that, and can also cause complications for the mother later on if she wants to have other children. So this is not really the standard of care, but it's been being performed in more and more places, and perhaps as the technique is refined and becomes less invasive, it may be even more promising.
Can you tell us how you decide? Do you implant shunts or do ETC? Is it there are some indication for ETC?
Right. So for babies with spina bifida that have hydrocephalus, I treat virtually all of them first with the ETV combined with CPC that we just talked about. The reason for that is that it works most of the time, and when it works, it avoids a lifetime of shunt dependence and the shunt complications that come along with that over the years. If it doesn't work, then the baby winds up with a shunt, but most people feel that it's really worth trying that as the initial operation. For other causes of hydrocephalus, there are some other considerations. For instance, hydrocephalus that is caused from meningitis where there has been infection in the fluid outside the brain and spinal cord that can lead to scarring of those spaces. The ETV is not as successful. Also for hydrocephalus, that results from a hemorrhage. If that hemorrhage has gotten to the outside of the brain, into the fluid spaces outside the brain, also the failure rate is very high. So if I see with an MRI scan that there is scarring in the spaces outside the brain where the fluid needs to go to be absorbed, I do not recommend ETV in those cases because the failure rate is very high and I just place a shunt. But in children that have had an infection or a hemorrhage that's just inside the brain, the procedure can be very successful. So if there is not evidence of scarring outside the brain in the outside fluid spaces, then I will usually recommend that as the first treatment to try. For other congenital causes of hydrocephalus, we've shown that the combined ETV and CPC procedure is very effective, similar to what we've shown with the spina bifida patients. For instance, in children with congenital aqueductal stenosis, in the newborn period, in the first few months of life, if you add choroid plexus cautery to the ETV, our success rates are between 75 and 80% in those babies. If you only do the ETV alone, it's about a 50% success rate, so it's important to do the combined procedure. We've had very similar results in children that have hydrocephalus secondary to encephalocele, and also children that have Dandy-Walker malformation, which can have hydrocephalus associated with it. So for congenital causes of hydrocephalus, this is a very, very good treatment with a lower failure rate than for shunts. And for secondary causes of hydrocephalus from hemorrhage or infection, it really depends on whether or not there is scarring on the outside fluid spaces as to whether I decide to recommend this or not.
Mm-hmm. Is it ETV age-related? Does it have some best age to perform it?
If you only are doing the ETV, age is very important. So this is why I don't do ETV only in babies. In children that are under 1 year of age, the ETV, for all reasons, is not very successful. Less than 50% of the time that will work. As a patient gets older, it becomes more and more successful, and so age is very important. But this is why we add the plexus cauterization in the early months of life, because when you do that, it brings the success rate for the infants up to what the success rate is for the older children.
Mm-hmm. And the situation, if the child already has a shunt, can you perform ETV?
You can, if the ventricles are big enough to be able to put the endoscope in and do the work. What I never do is operate on a child who's doing well. So a child with a shunt, sometimes the parents will ask, well, can we just try doing the ETV and get rid of the shunt? Well, I don't do that because there's no guarantee that child will need another operation. When I do this is in the context of a shunt malfunction or infection, where the child needs an operation anyway. And we can take that opportunity in some cases to remove the shunt, do the ETV, leave an external drain for safety so that we can monitor the pressure and drain fluid in the post-operative period as the child needs, to test and see over a few days whether the ETV is working well enough for that child to be without a shunt. If it works, then we can remove the drain and the child can leave the hospital without a shunt. If it doesn't work, then we have to return to the operating room and place a shunt. But it is an option, and we've very often been able to free children from shunt dependence, which is a very big thing in their life and in the family's life.
One question that troubles many parents. Does the child with regulated hydrocephalus have some restrictions in everyday life, in activities, in sports, and something like that?
Yeah, and that's a good question, and I think the concern there in the past has been that if a child has a shunt, that if they're involved in some athletic activity, that they might break the shunt, and that is possible. But it doesn't happen very often. I've seen broken shunts when the child was struck right on the shunt. For instance, I can think of one patient of mine from years ago that was a spina bifida patient and used forearm crutches, and he was in the bathroom and slipped and struck his shunt right on the edge of the sink. Now, he wasn't playing football or anything. He just fell and happened to hit his head the wrong way. The shunt became disconnected, and we had to operate on him to fix the shunt. But I have many patients with shunts who are involved in swimming and gymnastics and playing soccer and other sports, and my policy for those children is to not restrict them in any way. I think that's worse than taking the very small chance that something might happen to the shunt. Something might happen to the shunt no matter what you do. To tell a child that he can't play, that he can't swim or he can't be involved in gymnastics or whatever he wants to do, karate, I think is not, in my opinion, that's not what I recommend. There are some activities that I do ask patients not to do. And these are activities that I think are not good anyway. For instance, boxing. I think boxing is bad for your brain even if you don't have a shunt. And so I don't give permission for that. In patients that have hydrocephalus that's been successfully treated by ETV, it's even less of a concern because there's nothing to break. Once you have been successfully treated by ETV and you're stable and going along fine, the likelihood that something is going to happen to make that go wrong is very, very slim. So those children I consider, I don't restrict them either. So treated hydrocephalus, I let the children do whatever they're able to do. Another common question that's maybe related to that is I'm often asked if a child with a shunt can fly on an airplane. And the answer is yes, they can. It's not a problem.
Okay, that would be all. Thank you very much
for
your time.
All right. You're welcome.
Ist gut.